This is a short lecture on how we should approach all undifferentiated patients in the emergency room. The undifferentiated patient is a little bit different than what you may be used to on the inpatient setting, when the patient has now been partially or completely differentiated and the focus is now on managing a specific disease that has been diagnosed, or really focusing on the last two or three things on your differential that you're trying to rule in or rule out. It's also different than the patients that you see in clinic that may have a more documented history within your system, and also they may be patients that you know very well personally, and you'll be more apt to pick up subtle nuances, such as your normally stoic patient that never comes in for anything is now complaining of something. You're probably going to take that patient more seriously than the patient that comes in with every chief complaint, comes in for left pinky pain or something like that. So in the emergency room, you're operating with very limited data. These are patients that may not be part of your medical record system, and these are patients that you yourself may not know personally. The other thing to consider is that patients that have self-selected to come to the emergency room, by definition, have higher risk chief complaints. These patients have determined that their symptomatology is too severe to wait for their next clinic appointment, or too severe for their local urgent care to handle. This is another way of saying that you should take all patients coming to the emergency room seriously and start with that default position. When I walk into a patient's room, I assume that they have a life-threatening critical illness, and then I focus my encounter on trying to convince myself that that is not going on. I'm not saying that you should do $1 million workup on every patient. What I'm saying is you are less likely to miss critical illnesses if you take your patients seriously and then slowly de-escalate as you find out that their symptom is not something concerning, or you've used evidence-based methods to rule out life-threatening things. You don't want to be jaded by the system and automatically have your default position be that every patient that presents to the emergency room is full of BS. Yes, I understand that we live in a broken medical system where patients have a much lower threshold than they should have to present to the emergency room. And a patient may be coming to the emergency room not because they think their symptoms are so severe that it needs to be emergently evaluated, but it may be more because they have no access to primary care, have no medical insurance, or don't really understand how to navigate the medical system because it can be daunting. But these are things that you can easily determine by having a conversation with the patient and then performing your evaluation. For some patients, it may take me a few minutes to figure out that this is probably not a life-threatening chief complaint. For other patients, it may take a few labs or imaging tests or some observation time for me to determine that. But you always want to first assume that the patient has a critical illness and then slowly de-escalate as you get more reassuring data. In reality, every patient encounter is a case. You are a detective on a case and you're trying to solve what is going on. Another way to think about clinical encounters in the emergency room is you're trying to solve a 1,000-piece puzzle and you really only have 5 pieces at your disposal initially. It would be very hard to figure out what that puzzle is going to be, but as you slowly collect more pieces and gather more data, eventually you can start guessing as to what the puzzle may be. So I like to think of myself as an emergency medicine detective, where my first goal is to solve the case of, could this be a life-threatening illness? This case is always solved on all patients that go home, because we do not discharge patients whom we think may have a life-threatening illness. Patients that get admitted have been selected to have a critical diagnosis that requires inpatient management, or a diagnosis has not been made clear, but the presenting chief complaint
or findings are concerning enough to where it's not safe for the patient to be discharged. Our second job is to stabilize critical patients. We sometimes do this in the process of working through our differential. And once we've ruled out badness and we've stabilized our critical patients, our third job is to then double back and figure out what is most likely going on. This seems counterintuitive and likely the opposite of what you learned in medical school, but the reason we think this way is because in the initial stages of the undifferentiated patient, when there's very limited data, it's sometimes easier to start with ruling out what isn't going on than it is to rule in what is going on. Because again, you have very few pieces of the puzzle, you have very few clues to try to solve the case. And then while we work on stabilizing the patient, gathering more data, then we double back and then try to figure out what is most likely going on. And there's only 6 ways to do this. There are only 6 things that you can use as clues to try to solve a case. You have your history, your physical exam, labs, imaging, consults or consultants, and time, observation periods. And we can add chart review as 6A. That's it. This is all we get in order to solve our case. So if you come to me with a patient where you think the history was not very good, the patient was a poor historian, or there was a language barrier, and you tell me, man, that physical exam, I'm not that confident, I don't really think he has abdominal pain, but he's really obese and doesn't really give me a good exam, that means that you'll have to rely on your labs, imaging, and some of these other things on the list to finish your encounter. It would be very difficult in that patient to just confidently say I've clinically diagnosed or I've clinically ruled out all these things because your history and exam were not very effective. And this is especially true when you're an intern or a medical student where you have a lot of the book knowledge but you don't have the clinical knowledge. You don't have the clinical experience and calibration that comes with the residency and practice, where you have seen enough permutations of the same chief complaint to know that common diseases can present atypically. You haven't seen enough of those zebras that can fool you, and you maybe haven't yet realized that while you've read that a certain disease can present with a triad or a pentad, most of the time patients don't really show up that way initially. And this is why medical training and residency is so important, because this is the only time you get to calibrate yourself. This is the only time you get to see if and correlate your physical exam or your history with lab findings and imaging. When you start off, you should be a little bit more conservative and rely on your attending and your senior residents to kind of help guide you and calibrate you to know when it is appropriate to work something up and when it's less appropriate, and ask them why. But the main point of this lecture is to highlight the fact that we really only use these things to solve a case in the initial phase. And really, if you don't have one of these things, you have to rely on the other ones to help you solve the case. And the reason we think this way in the emergency room is because the bandwidth required to rule out disease when you don't have much information is a lot less than it is when you're trying to guess what the exact right answer is. Another way to understand how we think is to ask yourself one question. That question is, what percentage of life-threatening conditions do you feel comfortable discharging without treatment or workup? I think everybody's default answer to this is going to be 0. But be honest with yourself. What's your answer? 1%? 2%? 10%? Do you feel comfortable discharging a patient if they have a 10% chance of having a life-threatening condition and dying? In our current medical legal environment, 2% is the closest to the right answer. Obviously, we
all don't want to miss any life-threatening illnesses, but realistically, that is an impossible goal. And this reality can be very frustrating when you're a medical resident that's completely overworked and hasn't had a day off in a while. You probably find yourself wondering, why did the ER admit this syncope patient when they were completely asymptomatic now? Or why are they consulting me on another chest pain patient that has non-dynamic EKGs and 2 negative troponins? That reason is because these patients have a non-zero risk of a life-threatening illness. That patient that gets admitted for cardiovascularly mediated syncope is especially frustrating because you do a lot and usually the diagnosis remains unclear after an inpatient stay. However, what you gain from that admission is that you've now determined that this patient is at least stable for an X amount of time and can continue the investigation as an outpatient. The reason you got consulted on that intermediate risk chest painer by heart score is because we have evidence-based data, prospectively validated data that shows intermediate risk patients have a 12 to 16% risk of a major adverse cardiac event at 6 weeks. And while they might look stable in the ER initially, that percent risk is higher than our industry standard, and therefore we need to have a consultant, a specialist, weigh in and determine whether or not it's safe for this patient to continue investigation as an outpatient. And that provides you with a glimpse of how the emergency medicine brain works. And while this video stretched the definition of short, I hope you enjoyed it.